Assalamu alaikum. This is the presentation for medical students by Dr. Mumtaz Ahmed Umar, and today's topic is chronic suppurative otitis media. Definition: chronic suppurative otitis media or CSOM, it is defined as a long-standing infection which is of more than 3 weeks of the middle ear mucosa lining the middle ear cleft and characterized by intermittent or persistent ear discharge through a permanent tympanic membrane perforation. So what is middle ear cleft? Middle ear cleft, it includes the eustachian tube, the middle ear proper, attic, adytus, antrum, and the mastoid ear cell systems. Epidemiology: incidence of chronic suppurative otitis media is higher in developing countries because of the poor socioeconomic standards, poor nutrition, and lack of health education. It affects both sexes and all age groups, although it is more common in the children, and it runs for years if one don't take proper care of it. Then infection, it also depends upon the virulence of the organism and immunity of the patient. Types of CSOM, there are basically two types: tubotympanic CSOM, which is also known as the safe type, and aticoenteral CSOM, which is the unsafe type. Alternative classification: the chronic suppurative otitis media, it is further classified into mucosal, which is the tubotympanic, and squamosal, which is the aticoenteral disease. The mucosal is further classified into active disease when the ear is actively discharging, then the quiescent, inactive, or healed, or the adhesive otitis media, whereas the squamosal, it is divided into the retraction when there is only the retraction pocket in the attic region, or the ear is actively discharging with attic perforation or marginal perforation. Tubotympanic is known as safe or benign type because it usually involves the mucosa of the middle ear cleft, especially the antero-inferior part, meaning the eustachian tube and the mesotympanum. And secondly, it does not cause any serious complications, but there is always associated permanent central perforation. We discuss this later on. While aticoentral, it is an unsafe or dangerous type because it involves the postero-inferior part of the cleft, mainly the attic, antrum, and the mastoid region, and it is associated with attic or a marginal perforation. So tubotympanic CSOM. So why tubotympanic disease is safe? Because there is no risk of bone erosion. It is not known to cause intracranial complications. The discharge from the middle ear, it flows freely through the perforation in the pars tensa. The perforation in the pars tensa, it is surrounded by a rim of intact drum. So meaning it's a central perforation. So central perforation is the perforation in which the margins of the perforation, they are surrounded by the portion of the eardrum or intact drum or the tympanic annulus. So the annulus is intact in all these cases. Etiology: the disease, it usually starts in the childhood due to inadequately treated acute suppurative otitis media. Thus that acute suppurative otitis media, it causing a persistent perforation which becomes infected again and again. Then any ascending infection, presence of focal sepsis in the nose or throat, ascending infections via the eustachian tube can reach the ear through the infections of the tonsils, the adenoids, or the sinusitis, or the patients who have the deflected nasal septum or inferior turbinate hypertrophy, meaning the problem in the nose, it can affect the ear again and again. Or any traumatic central perforation which becomes secondarily infected can lead to chronic suppurative otitis media. Bacteriology: The main infective organisms, they are usually the gram-negative bacilli, especially the Pseudomonas aeruginosa, Escherichia coli, and B. proteus. These organisms, they are not commonly found in the respiratory tract. However, they are found in the skin of external canal, and from there they gain entry into the middle ear and cause infection. Pathology. The disease in the tubotympanic CSOM, it remains localized to the mucosa, as already mentioned, especially to the anteroinferior part of the middle ear cleft. Then the pathological changes which are seen are the perforation of the pars tensa. It is a central perforation and its size and position, it varies. We'll see later on. The position of the perforation will be in association to the handle of malleus. In front of handle of malleus, posterior to handle of malleus, inferior, subtotal, it depends, but we'll see it later on. Then middle ear mucosa. The mucosa in the active disease may be edematous, congested and velvety, while it may be normal in the quiescent or inactive disease. Polyp. Sometimes a polyp, which is a smooth mass of the edematous and inflamed mucosa, can seen protruded through a perforation and presents in the external auditory canal. It is usually pale in contrast to the red or pinkish polyp of the eticoantral disease, and it usually don't bleed as the polyp of the eticoantral disease, it bleeds. The ossicular chain, it is usually intact and mobile, but may show some degree of necrosis in chronic, in long-standing diseases, especially of the long process of incus. Then tympanosclerosis can also be there. It is basically hyalinization and subsequent calcification of the subepithelial connective tissue. It is seen in the remnants of the tympanic membrane or under the mucosa of middle ear, or especially once the eardrum, if it heals, as I have said in the type, healed otitis media, then there are scattered tympanosclerotic patches also visible. Tympanosclerotic masses may interfere with the mobility of the ossicles and cause conductive deafness. Then last but not the least, fibrosis and adhesions. They are the result of the healing process and they further impair the mobility of the ossicular chain, or they can even block the eustachian tube. So stages or further stages of the tubotympanic CSOM, as already mentioned, the acute stage, which is the active mucosal disease, then the quiescent stage, in which there is recent history of the discharge but no active discharge at the present time. The inactive mucosal disease, it's a dry perforation and the disease is inactive for weeks. And then the healed stage, once the perforation is get healed. So active stage, discharging at the time of examination. Quiescent stage, the discharge was in the recent past but there is no active discharge now. Inactive stage, no discharge for 3 to 6 months. As I said, weeks to months. If there is no discharge, then we will labeled it as dry ear and inactive stage. And the healed stage, the tympanic perforation has healed. You should know that as the eardrum, the tympanic membrane, it has 3 layers: the outer epithelial layer, middle fibrous layer and inner mucosal layer. So once the tympanic membrane it healed, it is devoid of the middle fibrous layer. So only the outer epithelial and inner mucosal layers. So this type of healed eardrum, it is thin and laxed as compared to the normal one. Though it may not cause any obvious problem, but one should know that the fibrous layer, if once damaged, it will not heal. So active or acute stage. So the ear will be actively discharging. The discharge is usually non-offensive, mucoid, mucopurulent, constant or intermittent, and it appears mostly at the time of the upper respiratory tract infection, or once the water entry there, it can give rise to active discharge. So as you can see that in all these 3 layers there is central perforation, but active discharge is present. It is here, I think it is the patient is on treatment because now the discharge becomes waterish, but here it is pure pus, mucoid and mucopurulent. But the discharge is usually not foul smelling. In quiescent stage, there will be perforation of the eardrum, but it looks little wet, although there is no active discharge here, but it looks wet, though the middle ear mucosa may be normal or it may be little hypertrophied, because the discharge, it has just stopped few days back. So depending how long the patient has taken the treatment, this stage, if the treatment has been taken for 10 to 14 days, then only observation is needed. But if the patient has used treatment only for 4 or 5 days, then he should complete the treatment of minimum 10 to 14 days. In inactive disease, there will be dry perforation of the eardrum. Perforation involves the pars tensa. This is the pars tensa, all this area. This is pars tensa, and here is the attic region. This is the attic region. So this is all in pars tensa with surrounding rim of the intact eardrum. I mean the eardrum, portion of eardrum is there in the surrounding. This is the annulus part. This one is here is the annulus, but it is intact. And the middle ear mucosa is normal and healthy. The healed stage, there will be, if you healing of the eardrum by a thin scar, tympanosclerotic patches may be seen. This is the tympanosclerotic patch. If you visualize the healed portion from the surrounding portion, so you can easily tell that here it is little thin than the surrounding eardrum. Symptoms. So ear discharge, as I already mentioned, it is profuse and mucoid and mucopurulent and non-foul smelling. It may be either continuous, constant or intermittent, and it is usually present at the time of upper respiratory tract infection. So during the history of associated nasal and throat problem should always be asked, and if present they should be treated side by side. And as already mentioned that this is a disease of middle ear cleft, so middle ear cleft contains eustachian tube as well. So most of the time the primary source will be present in the nose as well. The second reason for recurrent infection is because there is perforation. So once the patient he or she it will not take care of the ear or preventing from water entering the ear. So once the water it enter, it can give rise to recurrent infection. Then the patient may also have hearing loss. It is usually of conductive type, and usually it remains till 40 decibel if the ossicles they are intact, and if ossicles they become damaged, it will go up till 50 decibel. It usually don't exceed 50 decibel. Pain is usually absent, but once it is there, then it may be due to otitis externa. So signs or the examination findings. So first of all, after taking the history of the symptoms, you start the examination with inspection and palpation. But as already mentioned, it is usually a painless condition. So then comes the otoscopy. On otoscopy, a discharge will be visible. So suction and cleaning of the discharge has to be done. Sometimes the patient reports of a paradoxical effect, meaning that they say that they hear better in the presence of discharge rather than when the ear is dry. This is due to the round window shielding effect or round window baffle, meaning that it is produced by the discharge, which helps to maintain a phase differential, meaning that in the dry ear or the dry perforation, the sound waves strike both the oval window and round window simultaneously, thus cancelling each other's effect. However, it is a matter of debate now, and it is not proven always. And in very long standing cases, as mentioned, that mainly the hearing loss is of conductive type, as we will see in the tuning fork test. But in long standing cases, due to the toxins produced of the disease, they enter via the oval and round window, leading to the sensorineural element, causing mixed hearing loss. So, discharge is visible. After suction and cleaning, we will able to see a central perforation, and in some cases a polyp may be visible. On tuning fork test, which are the Rinnis test, Weber test and absolute bone conduction test, the Rinnis test in the affected ear will be negative, meaning the bone conduction will be better than the air conduction, and the Weber will be lateralized to the diseased ear in conductive hearing loss. Or if there is a bilateral disease, then Weber will be lateralized to the ear with more conductive loss. It is important. Okay, either it may be central in bilateral disease, meaning both ears have almost equal hearing loss, or it may be lateralized to the one ear, which will be more conductively deaf ear, while ABC will not be reduced. So we will see the types of perforation, or a perforation becomes permanent. You see, once when the perforation, we call it is a permanent perforation, as in CSOM. So perforation becomes permanent when its edges are covered by squamous epithelium and they doesn't heal spontaneously. So we can roughly say that the edges are epithelialized. So the central perforation may be small, medium, large, subtotal or total. Then the other perforation is the marginal perforation, which though present in the pars tensa, in the posterior superior part, but it involves the annulus. So it is a dangerous type of perforation. And attic perforation is also a dangerous perforation. So looking at these pictures, this is as already mentioned, the position of perforation will be in relation to handle of malleus. So this will be the anterior. If the perforation is here, it will be posterior. If it is here, as this one, it is inferior. Okay, so this is a small central perforation, anterior. This is a medium sized central perforation. This is a total perforation. This is not subtotal, this is large perforation. Subtotal will be a little bigger. I will show you in the next picture. This is the posterior superior part, the marginal perforation. The annulus is also damaged. And this is the attic perforation. We don't call attic perforation as central perforation, but we just call it an attic perforation. So these are the original pictures. So this is the small central perforation. This is a medium sized central perforation. This is a large perforation. Okay, and this is the subtotal because the rim is there. And the total perforation is the one in which there is only the annulus, surrounding annulus. This is the tympanosclerotic part, and this is the posterior superior part, more clearly visible in this area. And you see the granulations, they are also present. And this is the attic perforation with attic crust. The pars tensa is intact, but this attic region is involved. So how to investigate? So we may need to do the blood CP with ESR. ESR will show the chronic infection. Then the specific investigation will be ear swab for culture and sensitivity. It will show the infective organism. So best way to do this one is to first do small suction and cleaning, then do examination under microscope and take the swab from the edges of the perforation or the deep meatus. Okay, then other examination is the examination under microscope, then pure tone audiometry, and last is the radiology. Now, the role of X-ray mastoid comparison is very limited now. You can do X-ray paranasal sinuses to see the associated sinusitis or any other pathology in the sinuses or the nose. CT scan temporal bone is only limited in tubotympanic disease if the polyp is present and it is not resolving with treatment. Then we may need to do CT scan, as there might be an underlying atic disease also, for one reason, or secondly, we don't know from where the polyp is arising. Polyp can arise from the mucosal covering the horizontal semicircular canal, from the ossicle, from the facial ridge, anywhere. So if you just avulse the polyp, you can damage these structures. So to know more clearly, we can do CT scan, but it is not routinely done. So what is pure tone audiometry? It is an audiological assessment test which shows the degree and intensity and type of hearing loss. So it will show the conductive hearing loss. As already mentioned, hearing loss commonly ranges between 30 to 40 decibel. Up till 40 decibel it is mild, and up to 40 to 55 is the moderate. So mild to moderate hearing loss will be there in these patients, but it rarely exceeds beyond 50 decibel. And once it is 50 decibel, it means that ossicular chain disruption has there. It should be suspected. And I already mentioned the first thing which will be necrose is the long process of incus. Associated sensorineural hearing loss should arouse suspicion of toxic deafness, either due to the medicines or, as mentioned, in long-standing cases, the toxins, they can pass through the oval or in round window and affect the inner ear. But in such cases, the deafness will be of mixed variety. So this is how a pure tone audiometry will be done, has been carried out. This is the audiometer. The patient will be sitting in a soundproof room with headphones around him and the button in his hand, and different sounds are transferred to the patient through this machine, and whenever he is able to listen the sound, he will press the button, which will be shown in this graph, which will be shown in the machine. The minimum intensity and the frequency at which the patient will be able to hear. So at that point the graph will be marked. We will discuss that in the topic of pure tone audiometry. Now treatment. The first and the most important thing is the oral toileting, especially in the active disease. It includes the suction and clearance with a suction machine, or if the machine is not available, you can do the dry mopping with the cotton tape. And even when the debris are too much, you can irrigate the affected ear, but this should only be carried out by a doctor. Irrigation of the affected ear using warm saline mixed with 1.5% acetic acid or the white vinegar. Okay, we don't do this in every patient, but in resistant patients or not getting better with the treatment, we can do this thing, irrigation. Okay, but only, as I mentioned, by the doctor, not any technician. Then topical antibiotics with or without steroids administered after the culture report becomes available. So nowadays the medicines which are being used are the ciprofloxacin and ofloxacin, and in some cases tobramycin, gentacin and other chloramphenicol, neomycin. These drugs are lidosporin. These drugs are no longer used. Only if the sensitivity to these medicine there, we can only use in those such cases. Okay, in the book it is written neomycin, gentacin. Don't write those medicines because they are ototoxic and there is no longer used. Most commonly is the ciprofloxacin by the name Cipotic D with Cipro and Dexa, Cipocaine with Cipro and lidocaine, and plain Cipotic with ciprofloxacin. Ofloxacin is comes by the name of Quinoxi. And tobramycin with dexamethasone is Dexatop, and only pure is the Tobac and things like that. Systemic antibiotics, usually they are not needed in every patient, but only depend upon the condition and the associated diseases. If present, then we start with the systemic antibiotics as well. They include the quinolones or the third generation cephalosporins. Mainly the quinolones, the fourth generation quinolone is the moxifloxacin. It is effective, which we gave 400 milligram every day once. And the third generation cephalosporin is the cefixime, which comes in the oral. Others are injectable forms. Then, as I said, that the eustachian tube is involved, so we have to prescribe the antihistamines, which can be cetirizine or loratadine, and nasal decongestant in the form of oral or topical drops. Precautions, they are very important. The ear must be kept dry always, okay? You have to advise this to every patient that especially during bathing, the patient must use a cotton dipped in oil and squeezed and then used, and after taking bath remove it, or more preferably use the earplugs. Then pre-existing sinus infection should be treated, otherwise if the source stays there and you treat only the local area, the ear, then after some days the disease will recur again. The presence of focal sepsis in the throat should also be managed. Surgical treatment. The role of surgery is limited as a definitive treatment for tubotympanic type of CSOM, but surgery towards the eradication of, the aim is that surgery should be done to eradicate the focal sepsis. The surgery aimed towards eradication of the middle ear disease, and surgery aimed at reconstruction of the tympanic membrane with or without ossicular reconstruction. So in easy terms, we may have to do the surgery of the associated factors. If the patient has DNS, then it should be carried out. If he has infections in the tonsils, adenoids, or the sinuses, so they should be they can be managed surgically. However, as far the ear is concerned, the surgery can be limited mainly at the repair of eardrum, which is laryngoplasty, and if you eradicate the disease in the middle ear in form of granulations or some other pathology and repair of eardrum, it will become tympanoplasty. Tympanoplasty now further classified into different types. So tympanoplasty is defined as a surgical procedure in which it to eradicate the disease in the middle ear and repair the eardrum perforation with or without reconstruction of ossicular system. So then there will be different types. So simple repair of eardrum with removing of the disease of the middle ear is tympanoplasty type 1. So there are different types of tympanoplasty. So all the components of tympanoplasty can be further sub-classified into canalplasty, in which you repair the canal, the myetoplasty, widening of the external-auditory canal, myringoplasty, in which the eardrum is repaired, and ossiculoplasty, when the ossicles are also repaired as well. Ossicular chain repair is also done as well. So basically these two portions are main concern for the tympanoplasty. Surgical approach. How to approach the ear for surgery? There are basically three routes: in front of external auditory canal, through the external auditory canal, or behind the external auditory canal. So it can be endoral in front, through the transcanal, through the ear, and post-oral, which is the most commonly performed procedure. So the graft materials which are commonly used for tympanoplasty, this is a viva question also. It can be asked which graft materials can be used to repair the eardrum. So the most commonly or preferred one is the temporalis fascia, and then the perichondrium, tragal perichondrium. These two are the most commonly used graft materials. But for small perforations, fat can also be used, and in adhesive otitis media cases or some other cases, cartilage can also be used. The less common are the periosteum, vein, and dura. So you should memorize these things, especially the temporalis fascia, perichondrium, fat, cartilage. These are enough. Thank you. Thank you.